All right, so welcome once again to our today's presentation or tutorials on histology. Today is our first of two. Okay. So we are having a patient who visited a dentist with complaints of redness and edema of his mouth mucous membrane in a month after dental prosthesis. The patient was diagnosed with allergic stomatitis. Allergic stomatitis. What type of allergic reaction are we looking at in this question? So allergic stomatitis is what type of allergy? That is what the question is all about. And if you had been watching, or if you have been watching the video, or if you have been following the videos, we have done questions on allergies and the diseases that fall under each and every one of them. So just for the benefit of revision, I'll just go through them with you again. All right. So let's take one after the other. So let's talk about type 1 hypersensitivity. Type 1. Another name for type 1 hypersensitivity is immediate or anaphylactic or atopic or ranging. I repeat, immediate, anaphylactic, atopic, and then raging. All of these things are different names for type 1 hypersensitivity. And example of diseases that fall under this category include allergic and atopic disorders such as rhinitis. If I were you, I'd be writing this down. Rhinitis, hay fever, asthma, and then anaphylaxis. Asthma, hay fever, rhinitis. These are some of the conditions that fall under type 1 hypersensitivity reaction. Then type 2 hypersensitivity reaction. Another name is called cytotoxic reaction. Cytotoxic or antibody dependent. Antibody dependent. Example include hemolytic or autoimmune hemolytic anemia. Autoimmune hemolytic anemia. We have good pasture syndrome. Good pasture syndrome. We have Graves' disease. Graves' disease. We have myasthenia gravis. Myasthenia gravis. Myasthenia gravis. So again, these are the conditions that you can find under type 2. Now let's talk about type 3 hypersensitivity, also known as immune complex reaction. Immune complex reaction. Example of diseases or conditions that fall under this category include Artus reaction. Arthus, Artus reaction. SLE, that is systemic lupus erythematosus. So it is what, type 3. We have serum sickness. Serum sickness. We have rheumatoid arthritis. Rheumatoid arthritis. We have post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. We can even talk about vasculitis and so on and so on. Vasculitis, etc. All of these fall under type 3. Now, type 4 hypersensitivity, also known as delayed or cell-mediated. Delayed or cell-mediated. Example include contact dermatitis, allergic stomatitis, graft versus host disease. When we say graft versus host disease, it's more or less talking about transplant. So when somebody is, or when you transplant, a donor gives maybe the kidney to another person who's the recipient. At the long run, there can be what? A graft versus host disease, or there can be a reaction. That is type 4. We can talk about multiple sclerosis. And we can talk about tuberculin injection. tuberculin injection. All of these are all what? A delayed type of hypersensitivity. A delayed type of hypersensitivity. Like I said, we've already discussed this, but for the benefit of learning, that's why I'm going over it again for you. So looking at the question, we're having what? Allergic stomatitis. Allergic stomatitis. So what type of hypersensitivity comes to mind? Of course, type 4. And we say type 4 is the same as what? A delayed type of hypersensitivity. Delayed. So your answer should be what? Should be C. An electronic microphotography. Microphotograph shows a macrophagic cell with erythrocyte at different stages of differentiation located along 8 processes. This is the cell of the following organ. Now, what they're trying to tell us is that you have seen a cell that is having macrophages, and they are having what? A lot of erythrocyte, that's red blood cells, with different differentiation. That means when we talk about differentiation, that means they are not all not matured. All of them are, so some can be in the reticulocyte, some can be in blast form, some can be in the matured red blood cells. So the question now is, so all of this talking about what? Production of what? Of blood cells. So which organ is responsible for production of blood? Which organ is responsible for the production of blood? Obviously, this should be what? The red bone marrow. Because inside the red bone marrow, that is where erythropoiesis takes place. That is where erythropoiesis can take place. So over here, you are thinking about what? The bone marrow or red bone marrow. Red bone marrow. That is where the genesis of red blood cells begin inside the bones. Inside the bone. All right. Decreased blood supply to the organs causes hypoxia. Now, when we say hypoxia, we are talking about what? Inadequate amount of oxygen. And you and I know that when blood is supplied, or blood normally carries what? Oxygen with it, because it contains hemoglobin. And this hemoglobin has high affinity for oxygen. So when there's a decreased blood supply to organs, of course, it can lead to what? Hypoxia, because the tissues are lacking what? Oxygen. And they are saying that it activates fibroblast function. It activates the fibroblast function. And you know, these fibroblasts, they are found in the extracellular matrix. We have intra, and then we have what? Extracellular what? Matrix. Extracellular what? Matrix. In other words, it forms part of the connective tissue. Connective tissue. So the hypoxia has led to an activation of the fibroblast function. So the question now is that what element, volume of what element is increased in this case? Volume of what element is increased in this case? Like I said earlier on, we are referring to what? The extracellular matrix. The extracellular matrix. In other words, that forms part of the connective tissue, because fibroblasts are found inside the connective tissue, just like the collagen fibers are also found. And another name for the extracellular matrix can be called the intercellular substance, or the substances that are within the extracellular matrix. We call them what? Intercellular substances. Intercellular substances. And this will include the ground substances such as the prostaglandins, the glycoproteins, the collagen fibers, which form part of the connective tissues, and all of these things. The fibroblasts, all of these things form part of the extracellular matrix. But the substances together, we call them what? The intercellular substances. Intercellular substances. So that place will be highly what? Increased. So your answer is B. Is B. All right. We're having a patient who has undergone an amputation of the lower extremity. When we say amputation, we are more or less talking about a cut of the lower extremity, not a cut like removal. Okay, let's say your leg has been amputated or it has been removed. So sometime later, there was a painful nodules appeared in a stump. Amputations neuromas were found out at the microscopic examination. To what pathological process do those formations relate? Now, you and I know that when even when you get injured, okay, the place try to what? To heal. The place try to heal. Now, when it is healing, it means that another new cells have come in to replace the old cells. That is why it has healed. Okay, new cells are coming in. And most often than not, your skin always go through that process. Cell will die, another cell will come. Cell will die, another cell will come. And all of these processes, we call them what? Regeneration. Regeneration. Or a regrowth of lost tissue. And when the person was amputated, definitely tissues are gone. But now there is what? Regeneration or a regrowth of the lost tissue or the organs. There is what? A regrowth. So that stump that you are seeing or that painful nodules that are appearing is simply signifying that there is what? A regrowth of the lost tissue. There is a regrowth. There is a regrowth. There is a regrowth. So basically, we are dealing with what? A regeneration. 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 All right. So here we are talking about what? About E. Regeneration. Regeneration. All right. We're having a 22-year-old patient who was admitted to the hospital with complaints of heavy nasal breathing. That means the person is breathing heavily. Now, during examination of her nasal cavity, the doctors found thickened mucous membrane. Obviously, this person could be, most people call it catarrh, those kind of stuff. All right. But look at it. There's mucus thickening. There's a lot of mucus also there and infiltrate with erosions in the nose. Guys, look at it. There's nasal rhinoscleroma was diagnosed. The biopsy was taken. What type of morphological changes may be found? Again, I've gone through some of these specific granulomas when we're talking about, when we started with pathomorphology. We talk about all of these things. So again, for the benefit of those who just join us, I'll just brush through again for us. So all of these are what specific. Now, when we talk about specific granulomas, what it means is that when you see the diagnosis, there are some type of cells you need to see. There are some types of cell that you need to see. For example, if someone is having HIV infection, you will know that there will be a decreased level of what? Of the CD4 or the T cells. You will know there will be a decreased number of them. The same way. So when there's a rhinoscleroma, what kind of cells are you looking out for? Good. So if I were you, I'll write these things down. Now, in leprosy, you are going to see the Verkov cells. So that means that if the diagnosis was leprosy or a lepra, your answers would have been what? Verkov cells. Because Verkov cells are specific for what? For leprosy or lepra. Okay. Now, in rhinoscleroma, like we are seeing in this case, in rhinoscleroma, you are thinking of mucoulish cells. You are looking out for what? Mucoulish cells. So over here, your answer should be what? Should be mucoulish cells. Mucoulish cells. Now, when you see, or for example, in tuberculosis, for instance, you are going to see giant Langerhans cells. So over here, you would have seen what? Langerhans cells, if your diagnosis was what? Tuberculosis. Good. Now, in syphilis, you will see Gumma cells. Gumma. Gumma cells. In syphilis, you will see Guma cells, or Guma cells will be very, very what? Pronounced. Guma cells. So these are the basic granulomas and their cells that you need to look out for when you see the question. So over here again, we are talking about rhinoscleroma. So in rhinoscleroma, we are talking about Mikulicz cells. Again, do your possible best to watch all the videos that we have posted or we have done, or the video that you have all missed. Do well to watch them. So the answer is E. All right. The lungs of a premature infant is presented on electronic photomicrography of biopsy material. There's a collapse of alveolar wall caused by a deficiency of a surfactant. Dysfunction of what cells of the alveolar wall caused it. Now you know what the surfactant is. Your surfactant helps us. It helps us in breathing. Okay, so that is why when young, a baby is about to be born, and the baby is preterm, they have to inject the mother with prednisolone or corticosteroids. Why? Because not really corticosteroids, but dexamethasone. Yeah, it's dexamethasone. They have to give that hormone or that drug to help the baby to develop what? Surfactant. If the baby is a preterm, it must develop this surfactant. Otherwise, when the baby is born, it will be very difficult for the baby to breathe in and breathe out, because this surfactant serves as a surface tension inside the lungs or inside the alveolar cells. They serve as tension, surface tension, to prevent collapse of the lungs. Okay, to prevent collapse of the lungs. So now they're telling us that there's a collapse of the alveolar wall. And the question is, what type of surfactant, what deficiency of surfactant has caused it? So first of all, you must understand that there are two major types of these surfactants, or the alveolar cells. Two major types. We have two major types. That's the type 1 and then the type 2. Now, in type 1, these cells, they form part of the structure of the alveoli. I repeat, they form part of the structure of the alveoli, and they are involved in the exchange of gases. That's between the alveoli and the blood. They are involved in the exchange of gases. Now, in type 2 cells, or in type 2 alveolar cells, they are involved in the alveolar wall. The alveolar wall, the wall itself. That's what type 2, the alveolar wall. Oh, I was adding someone. Guys, a minute. Okay. All right. Good. So we're talking about the cell wall, the alveolar cell wall, and this contains excretory organelles that helps the lungs, or that prevent collapse of the lungs. It prevents collapse of the lungs because it's involved in the cell wall. The type 1 is involved in the exchange of gases. Type 2 is involved in the cell wall. And over here, there's a deficiency of the cell wall, or the type that controls the cell wall. So that means this is not a problem with respiration, but rather a problem with the wall itself. And so therefore, over here, we shall go in for what? For type 2 alveolar cells, or type 2 alveolocytes. Type 2 alveolocytes. So over here, your answer should be what? Should be A. Type 2. All right. So your answer is A. Now, during histological examination of the stomach, it was found out that glands contain very small amount of parietal cells, or they are totally absent. So either the parietal cells are in small amount, or they are totally absent. So the question is that what part of the stomach has been studied? In other words, you need to know your anatomy to be able to guess this answer, because, in fact, to know the answer. So you need to know the anatomy of the inner wall of the stomach. Okay, you need to know the anatomy of it. So, which parts of the stomach? We have the fundus part, we have the body, we have the cardiac, we have the fundus, then we have the pyloric part, then we have the body. So, which part of it contains these parietal cells? Which part contains the parietal cells? And of course, we are talking about the pyloric part, the pyloric part, the pyloric part. And these are responsible for the production of the gastrin. They're responsible for the production of the gastrin, or the gastric juice that we normally love to call it. They are responsible for it. So over here, we are looking at what? The pyloric part. We are looking at the pyloric part, the pyloric part. So here your answer is A, the pyloric part of the stomach. All right. A live vaccine is injected into the human body, increasing activity of what cells of the connective tissue can be expected. Now you have injected a live vaccine. The reason why we give a vaccine is to help the body produce what? An antibody, so that next time when this sort of antigen enters into the body is already immune to it, or it can easily fight it. That is the reason for a vaccine. So you are sensitizing the body to be able to produce an antibody that will be ready for any attack by the antigen. And the cells that are basically involved in all these antibodies are the lymphocytes and then the antibodies. And when we say antibodies, we are talking about what? The plasma cells, or the plasmocytes. The plasma cells differentiate to form all these immunoglobulins, or all these antibodies. It is the plasma cells. So plasmocyte and then lymphocyte will be more ideal, because we are expecting these things to increase inside the body, so that when diseases come, they will be able to fight it. So we're talking about what? The plasmocyte and lymphocyte. Plasmocyte and then lymphocyte. Why? Because this is a vaccine. So we want the immune system to be readily available to fight any invasion or any antigen. So your answer is A. All right. Now, in the blood of a 26-year-old man, it was revealed 18% of erythrocyte of the spherical ball-shaped flat thorn-like shape. You and I know that erythrocytes are supposed to be what? Biconcave. Erythrocytes are supposed to be biconcave in nature. So this one, there's an abnormal shape of the red blood cell. And an abnormal shape of red blood cell is simply called poikilocytosis. An abnormal shape of red blood cell is simply called what? Poikilocytosis. So in poikilocytosis, we can have a sickle cell. We can have a sickle cell, because sickle cell, meaning the shape is sickle, which is not the normal shape, an abnormal shape. So that's what poikilocytosis. Okay. Now, there's another erythrocyte were of normal form, which was what? The biconcave. That's concave disc. Like I said, the biconcave shape of the red blood cells. But over here, 80% of them is having what? Poikilocytosis. So then the question is, how is such phenomenon called? Now, having 80% of the cells being poikilocytosis is not really a cause for alarm. But if you have more than 50% of these abnormally shaped red blood cells, then that becomes what? A pathology, or it becomes a cause for concern. So over here, since it's 18%, it's not up to 50%, we can say this person is having what? A physiological poikilocytosis. A physiological poikilocytosis. But like I said, if it is more than 50%, then we are thinking of what? A pathological poikilocytosis. So over here, your answer should be what? Physiological poikilocytosis. So D should be your answer. Now, we'll talk about anisocytosis. Anisocytosis of red blood cells. This refers to cells of unequal size or blood cells of unequal. That means the sizes are not what equal, unequal sizes. Okay. All right. But over here, we're talking about an abnormal shape. It's not about the size, but the abnormal shape. All right. So here, your answer is D, poikilocytosis, and this is physiological. When the pH of the stomach lumen decreases to less than 3, the antrum of the stomach releases peptic that acts in paracrine function to inhibit gastrin release. Now you know that gastrin or gastric juice contains high amount of what? HCl, that is hydrochloric acid. It contains high amount of hydrochloric acid. So then having too much of hydrochloric acid means that the pH is very low. Now, don't forget the pH. If you do a pH, the low values means high acidity. High values means what? High alkalinity or alkaline is increased. So over here, to have a pH of less than 3, it means it is very, very acidic. Very, very acidic. So what do you want to do? You want to inhibit the release, or you want to give a proton pump inhibitor to prevent the release of these ions into the stomach, because it can lead to erosion or it can lead to ulcer formation inside the stomach. It can lead to ulcer formation inside the stomach. So the question says they release what? They release substances that inhibit the gastrin release. So the question is, what peptide was released? What peptide hormone was released? So over here, we are looking at what? At somatostatin. And somatostatin is actually an inhibiting factor. It's an inhibiting what? Factor. It is an inhibiting what? Factor. So over here, we could have gone for what? Somatostatin as the likely diagnosis, because in somatostatin, it is a hormone that inhibits a whole lot of what? Of substances from being released. That is somatostatin. Okay. But over here, we are referring to the GIT. We are referring to what? The GIT. In other words, we are referring to the gastrointestinal what? Tract. We are referring to the gastrointestinal what? Tract. And we have a specific hormone that is specific for the GIT. And that is called the growth inhibiting factor. The growth inhibiting factor. Actually, is synonymous to the somatostatin. It is synonymous to somatostatin. But Krok wants to be specific with the stomach, okay, or with the GIT. But somatostatin should have been the ideal answer. However, Krok prefers us to use the GIF, that is a growth inhibiting factor. The growth inhibiting factor. So here, Krok opted for what? For D, which is not wrong in its sense, because somatostatin actually means growth inhibiting what? Factors. Growth inhibiting what? Factors. But these are two, options that should be correct. So more appropriately, use the GIF, growth inhibiting factor, the growth inhibiting factor. So this will prevent the release of the gastrin from the mucus of the stomach. So over here, your answer is D. A 50-year-old male farm worker has been brought to the emergency room. He was found confused in the orchard, and since then he has remained unconscious. Heart rate is 45 and blood pressure is 80/40. That is low. He is sweating and salivating profusely. Salivating. So your clue here is sweating and salivating. Sweating and salivating. So which of the following hormones should be So the following drug should be prescribed. Should be prescribed. And you know, over here we're going to look at for what? For an anti-muscarinic what drug? An anti-muscarinic drug. Anti-muscarinic drug. And the anti-muscarinic drug here is what? Atropine. We have done this one in the physiologies and then the pharmacology. We've done these things. That's what I'm saying. You do well to watch the videos. We've done these things. So here we are talking about the atropine sulfate. Atropine sulfate. Atropine sulfate. So atropine sulfate is basically used to treat bradycardia. When we say bradycardia, we're referring to what? Low heart rate. It is used to reduce salivation. Used to reduce salivation. However, if you give excess of this atropine, it can cause a whole lot of what? Troubles like swallowing difficulty, palpitation, dizziness, thirst, dry skin, fatigue, tremors, and so on and so forth. Okay. And to treat it, you can use Proserine. Yes, to treat it, you can use Proserine. We've done these things. We've done them. But over here, our main concern is what? This person is sweating and is what? Salivating and is having what? Bradycardia. That is low heart rate. So you give what? Atropine sulfate to reduce the salivation and then to increase the heart rate. So over here, we are looking at for what? For atropine sulfate. Atropine. So your answer is D. Now, a 13-year-old girl with a history of asthma. So this is your clue. Asthma. And you know, in asthma, they are having difficulty in breathing. Why? Because their bronchioles are blocked, or the bronchioles have constricted and then they've blocked the airway. And when that happens, they develop asthma. So he came complaining with a cough, dyspnea, wheezing. Symptoms became worse, so severe that her parents brought her to the emergency room. Examination revealed dysphoresis, dyspnea, tachycardia, tachypnea. Respiratory rate is 42. That shows that this person is really suffering or is really gasping for air. The pulse rate was 110. Blood pressure is 130. Choose from the list the appropriate drug to reverse the bronchoconstriction rapidly. So what drug do we normally use to reverse bronchoconstriction? In other words, in asthma treatment, what drug do we normally use? And again, I've treated or we have done these things in our previous presentation. So do well to look out for them. At what point do we use cromolyn? At what point do we use salbutamol? Because usually we use what? How do you call it? To treat bronchial asthma, we normally opt for what? For a bronchodilator. And the bronchodilator here is what? Salbutamol. It will open the bronchioles for air to pass through. So in the emergency case, we normally use what? Salbutamol. So at what point do we use cromolyn? Cromolyn is a mast cell stabilizer. When we say mast, it's M-A-S-T, mast cell. And you know, if people having asthma, mast cell degranulate and it releases histamine. And these histamine that are released are what causes the bronchoconstriction. Though it will cause vasodilation, but it will cause bronchoconstriction. Histamine. And histamine is coming out from what? From the mast cell. That's M-A-S-T, mast cell. But over here, we are looking at the emergency case. So you give what? Salbutamol. But for a long-term prevention of asthma, you can use cromolyn. So over here, we are looking at salbutamol. So your answer should be B. Sorry, C. Salbutamol. All right. A doctor gave or administered allopurinol. Again, we have done allopurinol when we talk about the uric acid, when we talk about the purines, when we talk about gout. We said in gout, there's an increased amount of what? Uric acid. Increased amount of uric acid. And this uric acid are coming out from what? From purine metabolism. Purine is a form of a nucleotide. They are coming from the purine metabolism. Okay. So the question now is, okay, look at it. They said the person was given allopurinol. And actually, the choice or the drug of treatment for gout is allopurinol. It's allopurinol because allopurinol will prevent the last stage of how do you call it? Of uric acid synthesis. We want to reduce the uric acid that have been synthesized. Again, do well to check our previous videos because we've discussed it intensively, talking about the the uric acid cycle and all those things. We've talked about them. So this one was suffering from symptoms of gout. So what pharmacological action of allopurinol ensures the therapeutic effect? Ensures the therapeutic effect. In other words, what is the function of this allopurinol? And again, I said it prevents the synthesis of what? Uric acid. It prevents the synthesis of uric acid. So over here, your best choice should be what? Should be A. Inhibiting of uric acid synthesis. Synthesis. Look, if it increases uric acid, this is not increasing of uric acid excretion. No. It rather prevent the synthesis. The synthesis. All right. So your answer is A. And don't forget your xanthine and hypoxanthine. Xanthine and hypoxanthine. Please don't forget them. We've done all of this. And that's why I don't want to waste our time on them. All right. Now, the pulmonalis embolism. The pulmonalis embolism has suddenly developed in a 40-year-old patient with an open fracture of the hip. Choose the possible kind of embolism. Now, when we say embolism simply refers to the movement, okay? The movement of an embolus. When we say embolus, we're referring to any substance. The movement of a substance from one place to another inside the bloodstream. That's what embolism is all about. So embolism is the movement of substance from one point to another through the bloodstream. That is just it. So it can be foreign body, it can be air, it can be tissue, it can be fat, and so on and so forth. People who come with deep vein people who come with deep vein injury or inflammation of the deep vein in the lower extremities, they normally develop a clot or thromboembolism. Thromboembolism. That means a clot has formed inside the vessel or inside the blood. Clot has formed and that clot has break off. And the clot inside the blood, we don't call it clot. Outside the blood, we call it clot. But inside the blood, we call it what? Thrombus. We call it thrombus. So a clot is actually what? The same as thrombus inside the vessel. So this thrombus can break off and then pass through the bloodstream. And usually the place that it causes more harm is inside the lungs because, the lungs, it can block the airway and stuff like that. It can lead to what? Edema formation inside the lungs. So very, very serious. So that is what, if it is deep vein thrombosis, deep vein thrombosis, or DVT, deep vein thrombosis. Now, if the person too is also, on a higher altitude or is flying in a flight, they develop air or gas embolism. And people who have fracture, they develop fat or adipose embolism. I repeat, if it's a fracture, it is fat or adipose embolism. So over here, we are looking at what? At fats. Fat, because over here they said that there's a fracture. So by fracture, it means some debris from the fracture has gone and then locked inside the lungs, causing fat embolism. So your answer is what? Is E. Your answer is E. Of course, it can also be foreign body. It can also be a tissue. So anything can happen. All right, so your answer is E. But this one, I'm talking about fat because why? Because it's a bone. It's a bone or it's a fracture. Now, if you talk of thrombus, you are dealing with what? DVT or deep vein thrombosis or thrombophlebitis. All right. So the answer is E here. Okay. So we have hypertrichosis of the auricle. When we say hypertrichosis, we are referring to what? Excessive hair growth. Okay, even inside the ear. Hair growth inside the ear. They say this is caused by a gene that is localized on the Y chromosome. A gene localized on the Y chromosome. Father has this feature. Now, when we say something is located on the Y chromosome, that means it is found on the Y. XY is a man. So it can be found on the Y chromosome. So what is the probability to give birth to a boy with such abnormality? So assuming that this is H, that is what? Hypertrichosis. Assuming this is H. So since the father is having it, that means the father is having it. So it's Y, it's on the Y chromosome. Now the woman is XX, isn't it? Woman is XX. So now let's see the probability of having a boy with this disease. So let's do our pairing. So this will match up with this. Again, this will match up with this. Okay. Then we have the second X match up with this, and then match up with that. So over here means over here we have what? X, X, because X is here, X is here. Then we have what? X, and then we have X, and then Y. And hence we have X, Y. But the Y has what? A disease on it, which is H. Then again, we have what? X, 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 X. And then we have what? X, and then Y again. Y with an H on it. So now, the question is, how many of them are boys? We have 1, 2 as boys. So will they have the disease or not? Of course, do have the disease because they inherited the Y chromosome from the father, and the father has the disease. So that means that 100% all the boys will have the disease, but the girls will be healthy. So B is 100%. So 100%, all the boys or the male children will have the disease. Why? Because this is Y-linked, and the father will always donate the Y chromosome to the developing male. All right. On autopsy, a 35-year-old man, the focus of carnification of 5 centimeters in diameter enclosed in a thin capsule was revealed in the second segment of the right lung. In other words, there is what? A focused necrosis of this size. There's a focused necrosis of this size, okay, inside the lungs. Now, look at, you see, the focus consists of a tough, dry, friable tissue with a dim surface. For what disease are these morphological changes typical of? Of course, if you are seeing, how do you call it? A fibrous necrosis, which is surrounded by a fibrous capsule. Because they may understand that this is enclosed by a thin capsule. This capsule is actually what? Fibrous tissue. It's a fibrous tissue. So if you have a necrosis with a specific size, a focused necrosis enclosed by a fibrous capsule, obviously you are looking at for what? Tuberculoma. So this is a complication of tuberculosis. So over here, we're looking at what? Tuberculoma. If you check the pathomorphology that we did the previous time, we have highlighted the different types of complications involved in tuberculosis. I've given you guys talking about the infiltrative form, talking about the gaseous form, the cavernous form of tuberculosis, all of them. I have highlighted them inside the pathomorphology. So over here, we are looking at what? At tuberculoma. We are looking at a tuberculoma. Now, in lung cancer, it will be close to the mediastinum. We've done something like this before. It will be close to the mediastinum or at the hilum or the hilum. The hilum refers to the place whereby all vessels pass through inside the lungs. Okay. all vessels, or all vessels that enter into the lung. Let me put it that way. All the vessels that enter into the lungs. That's where you will find a lung cancer. Very, very common over there. So over here, we're looking at what? A tuberculoma. All right. In the microspecimen of a red bone marrow, there were revealed multiple capillaries through the walls, of which mature blood cells penetrated. What type of capillaries are these? So now, bear in mind that the type of capillaries that are found in hematopoietic organs. When we say hematopoietic organs, we're referring to organs that are responsible for production of red blood cells, such as the bone marrow and then the spleen. The bone marrow and then the spleen. These organs, they contain what we call what? The sinusoidal capillaries. Sinusoidal capillaries. Sinusoidal capillaries. Over here, we are looking at what? Sinusoidal capillaries. So your answer should be what? Should be A. Sinusoidal capillaries. They can also be found in the liver and in the lymphoid tissues, and then the endocrine organs. Endocrine organs. So again, these are found in bone marrow, the spleen, because these are hematopoietic organs. They can also be found in the liver, in the lymphoid tissues, and endocrine organs. Again, they have sinusoidal capillaries. Sinusoidal capillaries. So your answer is A. All right. Now, MRS present all signs of hepatic coma, loss of consciousness, absence of reflexes, cramps, convulsion, disorder of heart activity, recurrent respiration. What are cerebrotoxic substances which accumulate in the blood under hepatic insufficiency or under heart failure? When we say hepatic insufficiency, we're definitely referring to a heart failure, or basically we're referring to a heart failure. So now the question is, what toxicity or what has toxic the brain, or what has harmed the brain, basically? What has harmed the brain secondary to a problem with the kidney? You and I know that the kidney is responsible for a whole lot of what? Detoxification mechanisms. A whole lot of detoxification mechanisms in the body. So when the liver is failing, that means it cannot undergo the detoxification processes. And as a result, one of the substances that are very, very, very toxic to the brain is what? Ammonia. Ammonia. And this ammonia, it goes through the urea cycle to be converted to urea and to be excreted. That's if the liver is functioning. But here's the case, the liver is insufficient or the liver is failing. And over here, they've told you this person having what? Signs and symptoms of hepatic coma. Hepatic coma simply means hepatic encephalopathy. Hepatic encephalopathy. That means hepatic failure that is leading to a mental disturbances. Leading to a mental disturbances or loss of what? Consciousness or change in consciousness. All right. So again, the substances that are very toxic to the brain are what? Ammonia. 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 So the answer is what? Is D. Ammonia. Ammonia. All right. An autopsy of a man who died from a chronic cardiovascular collapse revealed a tiger heart. So this is your clue. Tiger heart. Tiger heart. When we say tiger heart, what are we referring to? Tiger heart simply refers to what? A fatty degeneration. A fatty degeneration. Fatty degeneration of the heart. Of the heart. So when there's a lot of accumulation of fat in the heart, we call it the tiger heart or fatty degeneration, meaning there is too much of fat inside the heart. Inside the heart. Too much of fat inside the heart. Now, this same phenomenon, if it is found inside the heart, we call it tiger heart. If it is found in the liver, we call it the goose liver. Goose liver, the goose liver. So sometimes in some question you will see there's fatty degeneration of the liver. They are referring to what? A goose liver. And inside the kidney, you call it fatty degeneration of the kidney. But over there, you will see a very white kidney, large white kidney, large white kidney. But back to our question. Over here, we're referring to what? The tiger heart. That is what? Fatty degeneration of the heart. And over here on the endocardium, we're having what? A yellowish white banding can be what? Seen. The myocardium is dull and a dark yellow. What process is it? Of course, this is what? Fatty degeneration. Fatty degeneration. So this is D. This is D. All right. The low specific gravity of the secondary urine was found out in a sick person. What is the most distant part of the nephron where concentration of secondary urine takes place? Concentration of what? Secondary urine takes place. Where? What is the most distant part of the nephron where concentration of secondary urine takes place? So over here, you must understand what primary or how the primary the primary urine are formed and then the secondary urine are formed. So primary urine is basically formed by filtration from the blood. Primary urine is formed by filtration from the blood. Then from the primary urine, certain substances are reabsorbed into the blood and other substances are excreted into the primary urine from the blood. Now, under normal physiological conditions, about 15% of the glomerular filtrate is reabsorbed in the distal tubule. I repeat, about 15% of glomerular filtrate is reabsorbed in the distal tubule. That means by the time it gets to the distal level, 50% of the filtrate or of the primary urine would have been what? Reabsorbed. It would have been what? Reabsorbed. Now, then most of the remaining 5% is also reabsorbed in the collecting tubule. The collecting tubule. The collecting tubule. Now, the amount of fluid that is, at this point, I'm talking about the collecting duct or the collecting tubule is called the secondary urine. So secondary urine is formed when primary urine have also what? Substances have been reabsorbed. Then we are not talking about what? We are not talking about the secondary urine. Talking about the secondary urine. So over here, we are talking about what? The collecting duct. The collecting duct. The collecting. That is where secondary urine takes place. Meaning at that point in time, everything that needs to be reabsorbed have been what? Reabsorbed already. So over here, we should be thinking of what? Of the collecting duct. The collecting duct. The collecting duct. Now, in the proximal convoluted tubule, that is where the first part begins. That is where the first part begins. All right. Or that's what the primary urine will be. Good. So the answer is D, the collecting duct. The collecting duct. All right. Blood sampling for bulk analysis is recommended to be performed on an empty stomach and in the morning. What changes in the blood composition can occur if to perform blood sampling after food intake? After food intake. So first of all, you must know that after a meal, neutrophil count and the mean corpuscular hemoglobin increases significantly. I repeat, when you eat a whole lot of neutrophils and the mean corpuscular hemoglobin, that is MHC, they increase significantly. They increase significantly. Whereas lymphocyte and monocyte count red blood cell distribution with hematocrit and others would decrease significantly. So I repeat, neutrophils will increase significantly, whilst lymphocyte, macrophages, or red blood cells will decrease significantly. So over here, after taking food, what will happen? There will be an increased level of what? Neutrophils. And when we say neutrophils, we are referring to what? Leukocytes. Leukocytes. So there will be increased content of leukocytes. Increased content of leukocyte. Increased content of leukocyte. So your answer should be what? Should be E. All right. Now, most participants of Mangaline expedition of the America to America died from avitaminosis. That is deficiency of what? An amino acid. Now, this disease declared itself by general weakness, subcutaneous hemorrhages, falling of teeth, gingival hemorrhages. What is the name of this avitaminosis? In other words, what type of vitamin deficiency will lead to hemorrhage, gingival hemorrhage, falling of teeth? Do you remember the reason why we ask people to take vitamin C when they're having, sore in the mouth, or when they're bleeding from the gums and stuff like that? Yes, it's because we are talking about what? Scurvy. So this is what? Vitamin C deficiency. Vitamin C deficiency. Vitamin C deficiency. And again, if you watch the videos on pharmacology and then physiology, we've talked about scurvy, we'll talk about vitamin C, ascorbic acid, we'll talk about the hydroxylation. The collagen synthesis is involved in collagen synthesis. That's sometimes when people are finding difficulty to heal, we give them vitamin C because vitamin C helps in healing. And that's why when people are suffering from sour in the mouth, or, a lot of problems in the mouth, we ask them to take vitamin C, because vitamin C will not only stop the hemorrhages, it can also help in healing. It helps in healing. So again, this person is suffering from what? Vitamin C deficiency. So the answer is E, scurvy or scurvy. All right. A histological specimen presents a receptor zone of a sensoepithelial sense organ. Cells of this zone are placed upon the basal membrane and include the following types: external and internal receptor, external and internal pharyngeal cell, stem cells, external limiting cells, and then external supporting cells. The described receptor belongs to which of the following? Now, if you know your histology very well or your anatomy very well, this is definitely talking about the organ of hearing. The organ of hearing, or the organ of Corti. This is talking about the organ of Corti, or the spiral organ. The spiral organ. And this is responsible for hearing, or this is the organ for hearing. This is the organ for hearing. And they contain all of these cells. They contain all of these cells. They have the internal and the external hair cells, also called the internal and external receptor cells. They have the internal and then the external pharyngeal cells, the external limiting cells, and then the cells of Claudius. The cells of Claudius. All of these things form part of the organ of Corti, or the organ of hearing. They form part of the organ of hearing. So over here, we're talking about acoustic. Acoustic simply means what? Hearing. Acoustic. 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 All right. Now, a patient died 3 days after the operation because of a perforated colon. A perforated colon with manifestation of a diffuse purulent peritonitis. Now, usually, when you are having a diffuse peritonitis, it means that peritoneal irritation is positive. When we say peritoneal irritation is positive, it means any little touch on your abdomen, there will be pain or there will be tenderness. And that means that perforation has taken place and then peritonitis has set in. So that's what this client is actually going through. died off. And if you don't take care, you can die easily. So the autopsy revealed that they were thickened and covered, the mucus were thickened and covered with fibrin film, isolated ulcers, penetrated in different depths, penetrated. Now, mucous membrane, there's necrosis, there's leukocyte infiltration with hemorrhage focuses or foci. What disease complication has caused this? What disease complication has led to the development of this thing? Now, look at something. They've told you that this autopsy revealed on what? The colon, or this can be what? The sigmoid colon, or the large intestine. So the question is, which of these diseases affect the large intestine or affect the colon? And your answer is what? Of course, dysentery. Of course, we are dealing with what? Dysentery, because dysentery primarily affects the colon. It affects the colon. And again, I have made a very good distinct differences between non-specific ulcerative colitis, Crohn's disease, dysentery, or shigellosis. Actually, dysentery also means what? Shigellosis. I've made a very vast differences between them. Okay, so please do well to watch the videos. Then we'll talk about the irritable bowel syndrome, irritable bowel disease. Yes, you can remember. Irritable bowel syndrome, irritable bowel disease, which I have explained all of these inside the video. So please do well to watch them. So over here, we are dealing with what? With dysentery or shigellosis. So your answer is B. Is B. Now we have a patient who was admitted to the hospital with asphyxia attack provoked by a spasm of the smooth muscles of the respiratory tract. So what it means is that asthma has led to the development of this what? Asphyxia. Now asphyxia can also mean inadequate supply of oxygen. Inadequate supply of what? Oxygen. So asphyxia can easily lead to what? Hypoxia. Okay, because oxygen is not entering. Why? Because there's spasm of the smooth muscles of the respiratory tract. So this can be a problem with what? An asthmatic attack. So this can be what? An asthmatic attack. But the question is, this attack was mainly caused by which part of the airway? Of course, we know in asthmatic attack, we are dealing with the bronchi. We are dealing with the bronchi. Then when it comes to the bronchi, the small bronchi has a lot of smooth muscles. They have a lot of smooth muscles compared to the large bronchi. They have a lot of smooth muscles. So over here, we will be dealing with what? With the small bronchi, or the small bronchus. That is for one. Small bronchus. All right, so the answer is B. An increase in intraocular tension. Increase in intraocular tension. Normally we call it what? Glaucoma. 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 That is what glaucoma. Glaucoma to me means what? Increase in intraocular what? Pressure. And the pressure is supposed to be around 16 to about 20, 22. If it's more than that, then we're having what? A glaucoma. Now they say there's an increase in intraocular tension is observed in the patient. You see, with glaucoma, secretion of the aqueous humor by the ciliary body is normal. Injury of what structure of the eyeball caused the disorder of the flow out from the anterior chamber? You know the anterior chamber contains a fluid called the aqueous humor. This aqueous humor helps in a whole lot of things inside the eye, lubrication and stuff like that. Okay. But now they are saying that the secretion there is normal. So what could lead to pressure? That means something is blocking the flow out. Something is blocking the flow out because it's supposed to flow out so that the pressure in there will be normalized. So the pressure in there will be normalized. So at what point will there be a blockage? So you ask yourself, what takes fluid out of the aqueous humor? That's all. Or what drains the aqueous humor? And your answer is what? The venous sinus. The venous sinus. So venous sinus are responsible for draining the aqueous humor. And you know, vessels in general are responsible for what? For drainage. Veins in general are responsible for drainage. They are responsible for drainage. So over here, simply put, don't stress your head, your mind. Your answer is what? Venous sinus. The venous sinus. So your answer is A. Examination of a 43-year-old patient revealed that his stomach has difficulties with digestion of protein food. Difficulties with digestion of protein. Gastric juice analysis revealed low acidity. And again, we talked about gastric juice, or we talked about gastrin. And we said gastrin are produced by what cells? Of course, parietal cells. They are produced by parietal cells. And again, we said the parietal cells can be located at where? Yes, at the pyloric part. At the pyloric part. You see how all these are all coordinating or correlating. If you understand it, it's always easy to answer your question. So over here, we are referring to what? The parietal cells. Because the question is, what function of the gastric is disturbed? What function of the gastric cells are disturbed? And your answer is what? The parietal cells. The parietal, because they are responsible for the release of gastric juice. And if it is reduced, that means low acidity will be present. And when low acidity is present and the right amount of enzyme is not there, definitely they can't digest the protein. So your answer is B. A patient has been given a high dose of hydrocortisol for a long time. You know, hydrocortisol simply means cortisone, right? So you ask yourself, what part of the cortex is cortisol being produced? That's all. That's all. Don't forget they have what? Three layers. G, F, R. 3 layers. So this refers to what? The cortex of the adrenal gland. The inside we have what? The medulla. Now inside the cortex we have 3 layers. People like to call it GFR. So at the glomerulosa, it is responsible for what? Aldosterone formation or mineralocorticoids. Aldosterone or mineralocorticoids, which is salt. Then the fasciculata will be responsible for what? The cortisol level or cortisone release. Then the reticulata. Reticulata is responsible for what? For the sex hormones. So you see, J refers to what? Salt. F, cortisol, that is more or less like sugar. Then if you enter inside, we have what? The sex what? Hormones. The sex hormones. So basically, that is just how it is. You see. So your answer here is what? So now if this person has been given a high dose of this hydrocortisone, this causes atrophy of the adrenal cortex. So which zone? Of course, fasciculata or fascia. Also known as what? Fasciculata. So your answer is E. Fasciculata. All right. Low level of albumin and fibrinogen was detected in the patient's blood. Decreased activity of what organelle of the liver hepatocytes can cause it. Don't forget all these albumins and fibrinogens, they are all forms of what? Proteins. So you ask yourself, which of the organs or the, not organs per se, but which of the, cells or the organelle inside the cell loves proteins? And your answer is what? Endoplasmic reticulum. To be specific, granular endoplasmic reticulum, because they help to do translation or transcription. Transcription and translation are done with the help of what? Endoplasmic reticulum. That is what? Rough endoplasmic reticulum. And a rough endoplasmic reticulum is also known as what? Granular endoplasmic what? Reticulum. Why? Because they contains what? Proteins. They contains proteins, or proteins are attached to them. So over here, if this thing is disturbed, that means transcription will be impaired. Transcription will be impaired. And again, we have done something like this similar in some of our tutorials. So please do well to revisit them again, because like joke, we are ending all these bases. We are ending them. So yeah, you are thinking of what? A granular endoplasmic net, basically reticulum. So the answer is A. Now when we say agranular, that means without, or this is same as smooth endoplasmic reticulum. But over here, this is rough. So the answer is A. Now, in a histological specimen, a parenchyma of an organ is represented by a lymphoid tissue that forms lymph nodes. The latter are arranged in a diffuse manner and enclose a central artery. Central artery. Please don't think too much. If you ever see something like this, straight up, spleen. Straight up, spleen. Don't think too much. That is the anatomy of the how do you call it? The spleen. And don't forget, there are two types of zone inside the spleen. We have the splenic pulp. We have the splenic pulp, and then we have the white pulp. If you've heard about it before, splenic pulp, that is PULP, pulp. Then we have the white pulp. All of these things are all there. But like I said earlier on, this is very, very specific for spleen. Unfortunately, there's no diagram to illustrate how the central artery is being present. But again, we are referring to what? To a spleen. To a spleen. All right.